were talking about platelet abnormalities in thrombocytopenia functional disorder. Vessel abnormalities would be the next one. One is increase in the fragility of vessels due primarily to either autoimmune disease or to inflammation. An example of that would be Enoch Shawline purpura, which is, you see bleeding out into the spaces here, produces a pretty impressive rash. And these people come in, they're usually in teenagers, late teens, that sort of early 20s, and it usually follows a viral infection, upper respiratory infection, and it's a local vasculitis. It's an inflammatory vasculitis. It causes rupture and leakage of blood contents into the extravascular space. You'll see this frequently.
What's a URI?
Upper respiratory infection, like I have, which usually, this will usually pop up about 2 weeks later. It's a local, there are several things that produce local inflammatory reaction to in vessels. There are other diseases that produce a systemic inflammatory reaction of vessels. These are much more devastating diseases we'll get into later. All right, thrombosis here. I guarantee you, when you get out on clinical rotation, some preceptor is going to say, what's Virchow's triad? This is Virchow's triad right here. Has to do with alterations in the endothelium, the flow, or the blood components themselves. Guarantee you, you're going to be asked about Virchow's triad in terms of producing a coagulant, producing a thrombosis. Here they are right here. When you talk about blood components, alteration of blood components, what you're talking about here is a hypercoagulable state, and I'll give you some of those here in a minute. Alteration of blood flow, stasis and turbulence. We talked about in anatomy what goes on with the auricles of the atria. They don't, blood just kind of gets up in those cul-de-sacs and becomes stagnant up there. That's where blood clots can form, or thrombi can form, and from there, bad news. Blood flow itself is interesting. Ordinarily, because the vessels are nice and clean in you young folks, blood flow has a laminar flow pattern. And as the blood goes flying through there, on the endothelial cell membrane itself, it actually produces sort of a low pressure, and the cellular elements don't come in contact with the endothelium normally. They're more in the middle of the pipe. This is good. You don't want platelets coming in contact with endothelium. But if you put something in the way, and I'll give you a bunch of examples here in a second, if you put something in the way, the blood now produces a turbulent flow, not a laminar flow, and you run the risk of initiating thrombosis formation. And the best thing is in physical diagnosis, you're going to learn when you listen to vessels. If I put my stethoscope on your carotid, all I should hear is your heartbeat. However, if you get atherosclerotic plaque buildup in the carotids, or in the subclavians, or in the renal arteries, or iliacs, what you hear is during systole, that blood flow goes over the plaques, becomes turbulent, and you hear it as a shh. So that's what it sounds like. You put the stethoscope here, and you hear shh, shh, shh. Ordinarily, you should not hear anything. that sound is called a bruit, B-R-U-I-T. A bruit tells you there's turbulent flow at that site, most commonly due to atherosclerosis. Here are some other reasons for producing non-laminar flow. Atherosclerosis, as I just mentioned. Diabetes is on there because it accelerates atherosclerosis. Diabetes itself is not, but because it accelerates atherosclerosis, it gets it on this list. Hypertension is another one. Bacterial toxins, chemical agents, and so on. Okay? Really the one that you're going to be dealing with almost daily will be atherosclerosis. Alterations of blood components. If the blood is too viscous, there are disorders where you produce too many red blood cells and the blood becomes thick. Polycythemia is the name of that disorder. Hyperproteinemia is another one, but that's pretty rare. Polycythemia is relatively common. The hemoglobin is the amount of, is a measure of the amount of red blood cells you have. Ordinarily in men, it's around 15 grams per deciliter. In disorders like polycythemia, or there's another one called hemochromatosis, it's a genetic disorder, the hemoglobin concentration can get up 18, 19, 20. So indicating that you've got the blood is too thick, the treatment for that is phlebotomy. You know, some people with hemochromatosis, they just go in once a month and give a unit of blood. That blood can be used. There's nothing wrong with blood. You just make too much. Also, the presence of procoagulants in immune disorders like systemic lupus, neoplasia can produce abnormal procoagulant type compounds. Neoplasias can produce all sorts of compounds that shouldn't be there, and it causes all sorts of different sequelae. We'll talk about those as you go through the year, but neoplasia should be on the list for everything. And then you also can have deficiencies of anticoagulants. Anticoagulants are protein C, protein S. These are circulatory proteins that prevent coagulation. If you have a deficiency of those, it can cause a hypercoagulable state. Like in the airline captain I told you about, one of the things that they did when they worked him up, they assumed it was because he sat all the time, because he's an international pilot, so he flies to South America, Europe all the time, so he's sitting for long periods of time. But they also worked him up for protein S and protein C deficiencies, which he did not have. And that's part of the normal workup of somebody presenting with a coagulation you can't explain. Factor V Leiden is factor V. The mutation of factor V is called the Leiden mutation. So when you hear the term factor V Leiden, that means you just have the gene for a mutated form of factor V, and that enhances coagulation. So those three are the most common hypercoagulable states you're going to encounter. Appearance of thrombi, different examples here. Arterial thrombi, do you have this on your slide? Okay, I made some changes, so I don't know what I sent to you. Arterial thrombi are certainly can form within the artery itself, also within the heart. If you have a myocardial, an MI, myocardial infarction, here's the infarcted myocardium right there. Over top of that infarction, you can get a blood clot formation or thrombus formation. That happens to be called a mural thrombus. A mural thrombus. So an emboli from the heart, one of the sources can be mural thrombi. If you have an MI, you want to watch that patient for several days as they develop a clot over their MI, over their dead muscle tissue, and to make sure it doesn't embolize later on. Okay? This is one of the reasons you put somebody on an anticoagulant when they have an MI. Mural, things like this don't appear to be occlusive. They're going to alter blood flow in the area, but they're not going to occlude blood flow. When these things break off and become in inner smaller arteries, or if they develop in smaller arteries, that's where you have occlusive disease. This is a thrombus in the aorta, and what happens here is you get fibrin is interspersed with platelets. Remember early on we talked about how the platelet plug forms, you get platelets and white blood cells integrated into it. Well, it kind of looks like the rings on a tree. These are called the lines of Zahn. And if you look at this thing right here, you can see a line pattern right there. They've cut through the thrombus and opened it up. So you've got mirror images here. But these are the lines of Zahn. This is what you get in arterial thrombi. Venous thrombi tend to not have lines of Zahn. They don't tend to incorporate the blood cells in them. So they do appear, as you see in the cadavers, really a dark color like that. And you see that nice clot, the thrombus really. There's pulmonary artery on either side. This is obviously a post-mortem tissue, so if that was truly the pulmonary artery, and these were the two lobar branches, this person's dead. Capillary thrombi, again, endothelial damage. Not much to say about that. Other than one example of capillary thrombi would be, pathology-wise, would be sickle cell anemia. The sickle-shaped cells can't make it through the capillaries, and they essentially form thrombi within the capillaries. Most notably in the capillaries associated with the joint capsules. Therefore, sicklers, they present a lot of times with excruciating musculoskeletal pain because of the joint capsules. They also tend to infarct their heart, their other viscera. It's a pretty devastating disease. Lifespan for a sickler is about in the 40s. It's a bad disease. Postmortem clots, this is what we see down in the cadavers here. One of the main differences between an arterial clot or an anti-mortem clot, a post-mortem clot, is that anti-mortem clots tend to stick to the wall. These don't. That's how you can peel them off the vessels downstairs. They also don't have lines of Zahn and current jelly. You know what current jelly is? Current jelly is the stuff you can buy. It's kind of a thick, gooey jelly. You get black currant jelly. Very good to make a reduction sauce and cook duck in it. Just thought I'd throw that out there. Sequelae of thrombus. Here we go, thrombolysis. So we have a clot sitting in the middle of this artery here. There's the clot. And different things can happen. One is, over time, you get white blood cells to evade the clot, particularly neutrophils will evade the clot. Monocytes will too. Monocytes can convert to macrophages, so they start eating away at the clot. That softens the clot. It allows for essentially recanalization with endothelial cells and fibroblasts to support them. And so you can have the clot, and suddenly you have flow again through the clot over time, and the clot can actually get opened up enough so that it becomes incorporated into the wall of the blood vessel. So you'll see that a lot of times in things like myocardial infarction where the patient actually survived. Fragmentation and detachment. This is the bad stuff. This is when you have a thrombus and it breaks apart and starts traveling down the arterial circulation. This is called a thromboembolism. A thromboembolism. So when you get that atherosclerotic plaque up in here, it breaks apart and travels, that's an embolism. It's not related to a thrombus. Thromboembolism is specifically related to a coagulum that has broken off and moved. The manifestations of a thrombus here depend a lot on where it's occurring and what it's impacting. By the way, this is something you need to understand, that if things happen slowly, your body will adjust to it over time. And one example of that is if you start having atherosclerosis in an area where over time, over years, the vessel diameter keeps getting smaller and smaller, your body will accommodate by growing new blood vessels around it. It's collateralization. So that's what they're talking about here, is that the severity of a thrombus or the severity of an embolism depends on whether or not you've already established the collateral circulation. Infarction simply refers to an acute blockage of the arterial side. And it's going to produce a downstream hypoxia or ischemia. In the brain, what happens is that the brain tissue distal to the clot, or thrombus, becomes what it says, liquefaction necrosis. The best way to describe it is if you were to take tofu and put it in water, you know, like little tofu blocks, put it in water and mix it up, and it's gooey in there, that's what an infarcted brain looks like. It's just, you know, like that. Soupy, thick, soupy. That's liquefactive necrosis. Of course, infarction is going to be most devastating to tissues that require the most amount of oxygen, like your kidneys, your brain, your heart. If a tissue, well, this is kind of what I've already said. Now, the appearance of an infarction can vary. If you have a tissue that has a collateral blood supply already established, a collateral arterial blood supply already established, like the small bowel or the large bowel with the marginal artery, you've got blood coming in from both ways. If you block one side, two things can happen. One is the other side will save it. The other is it will become ischemic, and the other side will be pumping blood into it and produce a big red bloody mass in that area. That's what's happened here in the lung. That bleeding from the other side into a collateralized area of the lung. It can happen in a lot of places here. Okay. Here's an example of where the clot or the thrombus infarcted an artery where there was no collateralization. And what happens here is that the distal segment appears white, and it typically is wedge-shaped because the normal arterial distribution would be like that. So it's going to clot, it's going to kill everything in a wedge-shaped pattern. And over time, that wedge shape becomes more and more obvious, as you see here in the kidney. Here's a perfect example of a spleen that was infarcted, and it just killed it. It's perfect. There you go. Okay. Infarction, again, depends on location and size. If you have a small infarction in the brainstem, it's likely to kill you. If you have a large infarction in the anterior lobe of the cerebral cortex, it's likely not to kill you. So size is important and location is important. And embolus is, now we're going from thromboembolus to just plain embolus. Free-floating mass, it could be anything. There was a friend of mine, a physician up in Edmond. He had a patient came in. He was complaining of something to do, a cough or something. Shot an X-ray out of him. Turns out he had a central line placed in a subclavian artery, subclavian vein, weeks before, or maybe even months before, when he was in the hospital. And so when you put a subclavian line in, one of the things you do is you put this, it comes with what's called a J wire. It's a little wire that has the ends in a J. All right? You use that wire, once you get the needle in, you send that wire through the needle, and then you pull the needle out. So now you got the wire inside the vessel, right? And it's not connected to anything. Then what you do is you use what's called a tissue expander, and you widen the hole where the wire is going in the skin. Remember, the wire's in the subclavian vein. And then you can take and run your catheter over the wire, and it goes in, right? Well, the thing is, they tell you is never let go of the wire. Never ever, if you don't remember anything else about today, remember this. Never ever let go of the wire. Because what happened in this guy, somebody let go of the wire, and it got sucked into his subclavian vein, and it wound up where?
It's hard.
And where beyond that?
Lungs.
Where? Where, it wouldn't get into his lungs.
Pulmonary artery.
It was in his pulmonary artery. So he takes an x-ray of the guy, thinking he's looking for pneumonia. He's got a J wire sitting in the pulmonary artery of this guy. So anything can embolize.
How did they not know that they lost the wire?
Oh, they knew they lost the wire.
They didn't fix it?
They didn't go get it.
Oh, wow.
I don't know. They did, he sent him to an interventional radiologist, and they were able to go in and pull the wire out. So it didn't cause any damage. You're probably not going to win a lawsuit unless there's damage. You won't win a lawsuit unless there's damage. But the fact that that was just pure negligence, they knew that wire got sucked. It wasn't like, where did the wire go? All right, so embolization, the first bullet point is rather obvious. Kind of all of them are. Types of emboli. On the arterial side, mural thrombi, you see there. This picture I added, is it on your thing?
No.
I think I just added it last night. It's not on your thing? Here's the aortic valve here. This is vegetation on the valve due to endocarditis. So vegetations, infection can break off, and if this is in the aortic valve, it can go systemically anywhere, to the brain, mesentery, anywhere. Okay. Oh, it says valve infections with vegetation. Obviously, something happened here. I don't know if this is an autopsy specimen or it was replaced, but that's what it looks like. Okay. Pulmonary embolism, we talked about here. Most of them are going to rise from the deep veins of the leg. I'll say this in anatomy, but the deep veins of the leg would include those not on the surface. So the saphenous vein, the great saphenous vein, the small saphenous vein, these veins out in here, they can clot, and that's just fine. They don't typically embolize. You don't even worry about it. It's only the deep veins that will, like the popliteal vein and so on, where these pieces can break off and embolize. Oh, it says right there, the presence, you should work them up for hypercoagulability. Protein C, acid, factor above light. Fat emboli, these things happen the worst cases are when they happen in young kids who break long bones. Most of the time, though, in kids, the long bones are, the marrow is called hematogenous. In other words, it's active red marrow. In you, in me, the long bones, the hematogenous marrow has changed over to fat. I think I've mentioned this before. Haven't I mentioned this before? So if you fracture a long bone, the problem is because a long bone, remember, bone marrow is a sinusoid. These fragments of marrow can enter the vascular space through these sinusoids, through these ruptured sinusoids. And you can have emboli of bone marrow, either red marrow, the hematogenous marrow, or yellow marrow, the fat emboli. And that's what this is illustrating here. Air emboli can occur anytime you get air introduced into the vascular space. When you start an IV or when you put a central line in, you always want to charge the line, that's what it's called, charge the line with saline or something. You want to get the air out and just have the liquid in the line. You don't want to start an IV with a line full of air. Air doesn't tend to go through capillaries, instead it blocks. Because of the surface tension, it blocks things. You don't want to do that. Another example of air emboli would be the bends from diving. When you go down, you are able to dissolve more nitrogen into your circulation in a more concentrated form. As you come up too fast, that nitrogen that was in solute comes out as bubbles. And it's the bubbles that block the joints, just like sickle cell, just like the other things we've talked about, and produce the bends. When you dive, you have to keep track of your nitrogen load. If you're diving all week, or you have to keep up with how much nitrogen is in your body. When you dive down to 30 feet, say for an hour, a tank will usually last you about an hour. When you come back up, you stop 15 feet below the surface. That's 1 atmosphere, right? You stop 15 feet below the surface for 3 minutes to degas before you go to the surface. It's just a rule, okay? The deeper you go, the more places you have to stop going up. It's kind of weird. If you go down to 100 feet, you only have you have less than 10 minutes on the bottom. You really don't have a lot of time to goof around. That's why the best diving is like at 30 feet. Everybody should learn to dive. It's fun. Anybody here dive?
Not like professionally.
1, 2, 3, 4. It is amazing. Okay. DIC.
Oh, yeah.
Are you gonna tell them a story about you falling asleep or what?
When did you dive?
Where? A few years back, Amber and Nikki, Professor Fetters, and my wife and I, and one or two other people, we decided we would go to Grand Cayman. So we rented a house on the north shore of Grand Cayman, a mansion. It was crazy. I'm telling you people, I will tell you how to vacation. You know, amazing. Cheap vacation. So you go down there and they'll teach you how to dive in a day. When I got back, I got certified. Just the most amazing experience. So I have a pool in the backyard, and during the summer, I go down and get a tank, $8. And so we have all the equipment, my daughter and I. So for $16, they can, when you're only at that depth, a tank will last you forever. So, you know, Sophie and Emily, my daughter, they'll play out there diving in the backyard. I mean, it's the cheapest form of recreation ever. And so, you know, when they would go away, I gear up. I mean, I would, one day I was home alone and I went down to the bottom. And there's a thing you do where you put your fins on the bottom, the point of your fins on the bottom, and you have a sort of a vest on that you put air in, and that regulates your buoyancy. So I had my fins on the bottom, and so I'm just lying there, and when I'd breathe in, I'd come up like that. So I had my buoyancy perfect. I breathe out, I go back down. So I go up, I go down. I fell asleep. I was down in the pool for an hour. It was the coolest thing.
So weird.
And then I just started, you know, I started doing it. I'd go take a nap. I did it multiple times. And people say, you fall asleep and you know, you're going to kill yourself. Well, I take oxygen will last you all weekend.
I
It's the coolest thing. My grandchild, she's a little kid. A scuba tank comes with a thing called an octopus, and if you just pull it out, it's an extra regulator, like for emergencies. So I'd take her and I'd grab her like this, put the regulator in her mouth, and we would go swimming around. Oh. I mean, it's the funniest thing. If you want to find me in the summer on the weekend, go look at the bottom of the DIC, this is bad news here. This is really bad news. What happens in DIC, either because of sepsis or eclampsia for some reason, you know what eclampsia is? During the term, late stage pregnancy, women start, you know, they'll start, the blood sugar will go up, the blood pressure will go up, they'll start peeing protein, they'll get these little petechiae all over them, and then their blood will start clotting. They'll also have they can also have seizures. Once they have seizures, that's called eclampsia. All of those other things leading up to it is called pre-eclampsia. Once you have a seizure, it's eclampsia. Anyway, that's one of the DIC is a complication of eclampsia. If you ever start seeing the little petechiae on a pregnant woman that's due to deliver and she's seizing, that is the start of DIC. You better get that baby out right there. Multi-system organ failure, people in the ICU, a lot of them die by DIC. What happens here is if you have like coagulation run amok, and it starts out in these small arterioles throughout the body, and as you start getting this massive small coagulation throughout the body, you use up coagulation factors. And as you coagulate everywhere, you remember the body's response to the formation of a thrombus is to lyse it, to break it down. So then you start as you're coagulating everywhere, you start putting these anticoagulation factors out that that enhance bleeding. And these people bleed out. The treatment for DIC, believe it or not, is clotting factors. DIC, you typically don't come back from DIC if that process sets in. It's very difficult to reverse DIC and save a person. I think that's it. Yep. Any questions? Anything we talked about today? Ready?
Is that the only place you scuba dive? Is the Grand Canyons and then your pool?
No, we actually went last year to a place called Cayman Brac,
Uh-huh.
GRAC, which is a sister island of Grand Cayman. Grand Cayman, it has a reef around it, so you have to pay to somebody take you out to the reef to dive. The Cayman Brac, it's the top of the mountain, so the whole, everywhere around it is a dive site. So you can see, 50 yards off the shore, they have these dive sites marked with buoys. You just suit up on shore, jump in, you don't pay an outfitter.
I dove at Stewart Cove in the Bahamas, and it's on Shark Week every year.
What?
Stewart's Cove, it's in the Bahamas, and it's on Shark Week every year.
Oh, no, I don't do sharks. I was snorkeling, you asked Professor Fetters this. I was snorkeling out in, so the